Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you, Brian. Yeah, I'm glad to be here and give part two. The talk was too big for just one session last time. And in the meantime, Bob Loffelbein chatted with me and he said, Bob, you didn't talk about MAC. I thought IRIS in the United States was all about MAC. You didn't even mention it. So I'm going to talk about MAC today, Bob, if you're on the call here. So that's going to be one of the infections we'll review. So this is part two, and I'll include some slides regarding just the definition and some setup slides that I included from the first talk, but not all of them. My disclosure is with Merck, I adjudicate cases for a new diagnostic test, or I did that last year. So I need to continue to report that, I think, for another year or so. These are disclaimers for the talk today from the ECHO grant. And then this is something we all need to remember about data considerations when we're giving any talk. Okay, so I'll start out with just a quick review of immune reconstitution inflammatory syndrome, the definitions of it and when it occurs and clinically what it presents as, and then we can get into individual OIs and some cases that accompany those particular infections. So just a reminder, IRIS is an illness that occurs in a person with HIV, and it has a temporal relationship to them starting antiretroviral therapy. It's associated with a decline in viral load, as well as a rise in CD4 counts. And this is the key point. It really has to be a clinical presentation with an unusual inflammatory course. Plenty of people will develop opportunistic infections after starting antiretroviral therapy. They don't all constitute IRIS. IRIS has to be an unusual inflammatory course for that particular infection. And you need to exclude alternative causes like progression of an OI, drug toxicity, the normal presentation of a new OI. Those need to be off the table for you to label someone as having IRIS. There are two versions. Paradoxical IRIS, which is the more common. This occurs when someone has a known opportunistic infection, is on therapy, is getting better on therapy, and then starts antiretroviral treatment and deteriorates after that. The second version is unmasking, and this is when someone has generally a disseminated opportunistic infection that is cryptic prior to starting antiretroviral therapy, but then becomes evident after starting ART with intense inflammatory symptoms. The clinical timing is usually within the first couple of months of starting ART, but it can range from just a few days to many, many months, 6 months and even longer. The median CD4 count, and this was taken from a meta-analysis of a lot of IRIS studies published a decade ago. Median CD4 counts in this meta-analysis was less than 60. And the mortality rate from IRIS is not insignificant, almost 5%. And it's much higher if the IRIS syndrome is involving the central nervous system. This is just a long list of clinical symptoms or illnesses that are how IRIS would manifest, and then the possible etiologies for each of those clinical symptoms or illnesses. So you can see there are many reported infections that lead to many different clinical syndromes. Okay, that's the intro. The three conditions that I thought I'd talk about today are Kaposi sarcoma presenting as IRIS, cryptococcal meningitis, and the unique problems when it presents as IRIS, and then non-tuberculous mycobacterial infections that present with IRIS. So first up is KS. And this is a case of someone we took care of at Harborview many years ago who had a very unfortunate outcome, but it illustrates a point that I think is key when considering someone with KS. So this 47-year-old gentleman with HIV presented with fever, fatigue, and dry cough for a month and a half after starting antiretroviral therapy. His physical exam revealed a high fever, soft blood pressures, tachycardia, tachypnea, and hypoxia. His chest X-ray and CT scan showed some interstitial thickening, small effusions, splenomegaly, and diffuse adenopathy. This is his chest X-ray presentation. You can see he has some blunted costophrenic angles and has confirmatory small effusions cross-sectional imaging. So his workup was extensive. He underwent bronchoscopy. Over the course of his hospitalization, he underwent bronchoscopy, bone marrow aspiration, inguinal lymph node biopsies. Everything did not reveal a diagnosis. So he was treated empirically with Bactrim and Levo for pneumocystis and community-acquired pneumonia. CMV antigen was detected in his blood, so he got ganciclovir. He eventually was treated with both ethambutol and clarithromycin for the worry about cryptic MAC. And then steroids were started when he was not responding to any of those treatments. He improved dramatically on prednisone and was discharged from the hospital on a prednisone taper, thought to have iris to something that was not diagnosed. He returned to work, his chest X-ray normalized, his T cell count rose to almost 400. 3 days after completing his steroid taper, he was readmitted with dyspnea, fever, and edema. The following day, he developed a consumptive coagulopathy, acute renal failure, ARDS. He was intubated. He was bronched. The bronch was unrevealing. And despite supportive measures that included antibiotics, high-dose steroids, he expired 3 days after admission. This is his chest X-ray on his first admission. This is the chest X-ray on the day of his readmission. And this was just the day before he died. And he did have an autopsy, and it revealed extensive KS in both lungs with very prominent atypical lymphocyte infiltration of those KS lesions. So we think that he died of cryptic KS and a KS inflammatory reaction. There's not a ton written on this. The incidence from a number of papers that are listed at the bottom of the slide is all over the map, from just a few percent up to 40%. The meta-analysis that I talked about earlier clocked in at 6.4%, and most of those cases being paradoxical. So patients who already had KS and maybe were on treatment for KS, but then got worse, and a smaller percentage, like this case, with an unmasking iris syndrome. The timing is days to months after ART, most within the first couple of months, and risk factors are the usual risk factors for iris, and those include low CD4 count, high viral load, disseminated infections, and a short interval between the time someone has their OI treated and the time they start ART. Another key risk factor for KS iris is concurrent steroid use. So risk factors for more severe disease and higher mortality are low CD4 counts, visceral KS, plasma HHV8 levels that are positive, platelets less than 100,000, and no chemotherapy being administered for the KS. The clinical presentation is what you would expect, with inflammation and edema of known KS lesions, new lesions in any location, but especially in the lung, pleural effusions, ascites, and the ascites can be a chylous ascites as well as just a bland ascites. Prevention is chemotherapy for KS. It's notable that chemotherapy for KS does not decrease the risk of someone developing KS iris after they start antiretroviral therapy. The treatment for KS iris is chemotherapy, doxorubicin or paclitaxel. And I think the important point, and it was illustrated by this case, is steroids have no role in the treatment of KS iris. In fact, they make it all worse. Any questions about that?
In that case, in the autopsy, did they have dermatologic findings, or was it just in doing the autopsy of the lungs?
He had only visceral KS. He had no oral KS lesions, and he had no cutaneous KS lesions.
Thank you.
Very surprising case and tragic case. Okay, let's talk about cryptococcal iris. I don't have a case for this one because I think everybody knows how cryptococcal disease presents, but there are some talking points and some controversies that we should review when reviewing this one. So there is an international definition of cryptococcal iris. It's published a decade ago in the Lancet Infectious Diseases. And it defines paradoxical crypto-iris as previously diagnosed crypto that's responding to treatment, and then with clinical criteria that happens within 12 months of starting antiretroviral therapy, which then is clinical deterioration with inflammatory features. And the inflammatory conditions are listed there: worsening meningitis, lymphadenopathy, new intracranial lesions, multifocal disease, and so forth. And also no alternative explanation for those symptoms. So previously diagnosed crypto, getting better, and then within 12 months of starting antiretroviral therapy, you get worse. For unmasking iris, cryptococcal iris, it's clinical deterioration due to previously undiagnosed cryptococcus that develops after starting antiretroviral therapy. And again, I think the key thing here is unusual, heightened, or exaggerated symptoms. So some of the same symptoms that I listed in the previous slide, but they've got to be off the charts, like way abnormal inflammatory symptoms with any of these conditions. Typically occurs within a month after starting antiretroviral therapy, and once again, no alternative explanation for those symptoms. So there are two key trials that spoke to the timing of antiretroviral therapy in patients with cryptococcal meningitis and what should be done regarding that treatment. The first was published over 10 years ago now by someone who was a former resident here at University of Washington and at Harborview. She conducted this study in her native country. I'm trying to remember, I want to say it was Malawi, but I'm not sure about that. It was an open label, randomized clinical trial, and patients were diagnosed with cryptococcal meningitis and HIV. They all received fluconazole at high doses for 10 weeks and aggressive pressure management. So one criticism of this trial is that they did not receive what we would give for cryptococcal meningitis, which is amphotericin and 5-FC. They got something a little bit less effective, at least for the induction phase of treatment. They got fluconazole. Intervention was also not what we would consider standard of care now, but all patients got D4T, 3TC, and nevirapine. Those that had antiretroviral therapy started early, got it immediately, meaning within 3 days of the diagnosis of cryptococcal meningitis. Those that had ART delayed was delayed after the initial 10 weeks, so 2.5 months after getting their crypto treated. And the primary outcome was mortality after 2 years. There were 50 patients, and the overall mortality was 62%, but in the patients randomized to the early arm, a median survival time was 35 days, and the 2-year mortality was 87%. And compare that to the patients in the delayed arm. Remember, the delayed arm was 2 months of fluconazole before going on to antiretroviral therapy. Their survival was almost a year, and the 2-year mortality was only 37%. This is the Kaplan-Meier curve showing the dramatic difference in mortality between the delayed arm, which was in the dotted line, and the early arm, which is solid line. So that's the first RCT about timing of antiretroviral therapy. The second larger study was conducted by Boulware and was published in the New England Journal 9 years ago. This is the COAT study, and it had a similar design to the previous one. Early ART in this study was less than 2 weeks. Late was over a month. There were 250 patients in each arm. Primary endpoint was 6 months survival. Patients were stratified by their mental status, their coma scale, and by whether or not their CSF counts were low, meaning less than 5 or greater than 5. These patients were treated with amphotericin and fluconazole, but again, they did not get a 5-FC, which has left the study out to some criticism. A 5-FC is more cidal for fungal infections than amphotericin and has good CNS penetration, but they did not get that as part of their antifungal treatment. The study was halted by the DSMB after 177 patients were randomized because there was a dramatic difference in survival. The patients who got ART started early had a survival of only 55%, while those who got it late, 70% survival. And again, these are the Kaplan-Meier curves for the overall population. You can see the ones that had ART deferred had better survival. And this is the individuals who had less severe crypto, paradoxically, with more white cells in their CSF, not very much different. For the patients that had bad crypto, which paradoxically is associated with low CSF white cell count, they did much better if their ARV therapy was deferred. So in the secondary analysis, mortality was associated with worse altered mental status and with individuals who had low CSF white cell count that was suggesting a more severe infection. And there was a trend towards more iris in the early treatment group. It was probably much higher than, or the difference was probably much more marked than this, but they had an odd definition of iris that excluded people from that definition who probably did have iris. So recommendations from this study are that anti-cryptococcal therapy should always come before ART. And in general, the time interval between ART and starting treatment should be 4 weeks, and consider delaying even longer if the patients had more severe cryptococcal disease at presentation marked by an altered mental status or a low CSF white cell count. So I wanted to bring up this abstract, which was presented at CROI several years ago now, and it is cited in the IAS guidelines as support for immediate ART in patients with cryptococcal meningitis. This particular abstract has never been published, but I'll talk about another study that maybe is related to this abstract that was published recently. But this one was never published. And it used patients in 3 retrospective cohorts, COHERE, NA Accord, and CENIX. And it was done to kind of mimic the COAT study. This abstract was retrospective and observational. And in fact, most of the deaths occurred in patients who did not get ART at all. There were equal number of deaths in those that did and those that did not get ART started early. But the difference between the groups was ART less than 2 weeks or ART greater than 2 weeks. And the greater than 2 weeks was not defined. And many of the patients may have been put on antiretroviral therapy at 15 days. You just don't know. And this was back from 1998 when we had not very good ART. So the ART may not have been very effective. There may have been less immune reconstitution and therefore a less deleterious effect of starting early ART. In the guidelines, or these are the IAS 2022 guidelines, they state for persons with cryptococcal meningitis with access to close monitoring and supportive care for adverse events, ART should be initiated 2 to 4 weeks after starting antifungal therapy. They give it only a B2 rating, and B means pretty good evidence, and but the 2 is not from RCTs. It means that it's only meta-analyses that is the evidence backing that recommendation. They go on to say data supporting a delay in ART initiation for persons with cryptococcal meningitis were largely generated in resource-constrained settings where access to close monitoring and supportive care may not have been as readily available, and in persons who were not being treated with INSTI-based ART. So I don't know what to make out of that, but it seems like an odd recommendation when we have RCTs that show a clear benefit with delaying ART. And we want to make this recommendation that's based on meta-analyses, retrospective, observational studies. It just seems peculiar to me. There was an editorial by Boulware this July in CID that commented on a paper by Engel that was in the same issue, and I think was in part based on that CROI abstract from 2014. And Boulware is the guy is the principal investigator for the COAT study, so he's got maybe some bias against something else. But I found his comments compelling. So when he talked about the Engel paper, he noted a large sampling bias in that paper with 630 patients with cryptococcal meningitis, almost half of whom were lost to follow-up, and 28 were excluded for missing data. So he started with 630, but he ended up with only 190 patients. And they took those 190 patients and they essentially virtually cloned them and then entered them into 2 hypothetical arms who started ART before 2 weeks or after 2 weeks. The median time to ART was 0 days in the early ART exam, which is, shorter than was done in the COAT study by weeks. And many of the deaths in the delayed arm occurred between week 2 and 4, which would have been categorized in the early group in the other RCTs that I talked about. Those who were never started on ART were put in the late group. So much of the comparison was really between early ART, which may have been 0 days, versus no ART at all. And many subjects who were censored at day 14 in the early group, many subjects were censored at day 14 in the early group. So any deaths that happened after that were only considered as part of the late group. So all kinds of problems with this retrospective observational study that somehow made its way to influence the guidelines, the AIS guidelines. So it just seems bizarre to me that we would pay attention to that data when we've got RCTs showing a significant benefit from delaying ART with cryptococcal meningitis. So prevention and treatment. Prevention, delay ART for 4 to 6 weeks after therapy for cryptococcus. In well-resourced settings, consider ART sooner. I put a big question mark after that. The treatment is to manage ICP with serial taps, drains, and shunts, enhance antifungal therapy while waiting to confirm that antifungal therapy is effective, that it's actually killing the organism. So you can put people back on liposomal amphotericin or increase their fluconazole at the same time that you're dealing with their iris. Some experts recommend a brief course of tapering steroids at 1 mg per kg per day. That's a relatively new and not evidence-based recommendations, because old recommendations where you don't use steroids when treating fungal infections. But that has made its way into some expert recommendations and are on the DHHS guidelines as well. So for Bob Loffelbein, MAC iris. We have a case here. This is another not made up. This is a case from Harborview, one of my patients, 23-year-old gay man with HIV, not previously diagnosed with HIV, but who presented with anorexia, dysphagia, and a 25-pound weight loss over 6 months. He also had night sweats, fatigue, and diarrhea. On exam, he was cachectic and apathetic, febrile to 38, hypotensive, tachycardic. He had thrush, seborrheic dermatitis, indurated purple plaques on his face, feet, and hard palate. His liver edge was enlarged. He tested positive for HIV. His T cells were only 14, and his viral load was 500,000. He declined to come in the hospital, but received several liters of fluid, was given fluconazole and Bactrim, and he went home. He came back to clinic a week later without thrush or dysphagia. He says he's been taking his Bactrim, but his diarrhea, fevers, and sweats continue, and now he had abdominal fullness and abdominal pain. His CBC and chemistries are listed here, showing that he's profoundly anemic. He bumped his LFTs, mostly a cholestatic picture, has a high protein gap. Stool O&Ps are negative. Blood cultures are negative for the following. Histoantigen is negative. Tests for MTB or exposure to MTB are negative. And his abdominal CT is shown here. You can see his bowel loops are opacified or with contrast or have air in them. All of this are just mesenteric, and then back here, retroperitoneal adenopathy. So he gets a biopsy that is just, this is not his biopsy. This is pulled from the internet, but it could have been his biopsy. This is a liver biopsy of somebody with disseminated MAC, just showing chock full of acid-fast organisms. So he started on azithromycin and ethambutol, and that results in a gradual reduction in his temperature, sweats, diarrhea. He is then started on ART, a dolutegravir-based regimen, and 3 weeks later presents with recurrent fever, abdominal pain, and a left-sided abdominal mass. And imaging is here, showing those nodes that we saw in the last CT scan are now liquefying and necrotic. And this represents non-tuberculous mycobacteria iris. He actually ended up having not MAC, but M. genevensi, but I just grouped it with MAC because it often behaves exactly the same way. So this is a study published some time ago, but there are not too many relatively good-sized studies of non-tuberculous mycobacteria iris. This one was published out of British Columbia, and a detailed cohort of 51 patients over a 10-year period. The incidence of NTM iris was 3.5% of all their patients who were started on ART with CD4 counts less than 100. Most cases were Mycobacterium avium complex, but some were M. genevensi, and some were AFB stain positive, but never grew. Clinically, patients presented with peripheral adenopathy or thoracic infiltrates, nodules, cavities, and pericardial effusions. And then an equal number also had intra-abdominal disease, like my patient, with necrotic nodes, abscesses, ascites, and adrenal masses. Median CD4 count in this cohort at the time of starting ART was 20, and at the time of the diagnosis of iris was 120. Median time to iris from symptom onset, from symptoms post-ART was 3 weeks, but the median time to diagnosis was 10 weeks. 80% of the patients received over 2 weeks of antibiotics, and the duration of their symptoms was 6 months. But 20% of the patients got no treatment directed at their NTM infection, and they had symptom durations of only 3 months and got better without any focused therapy against MAC. Just 9 patients received steroids, and they don't go into details, but most of those, 8 of the 9 who received steroids responded well. 10 patients died, 2 of them from MAC, 5 of them from other OIs, and 3 from non-HIV related causes. So the clinical presentation for MAC or NTM iris that would include other non-tuberculous infections are fever, sweats, adenitis. If the CD4 counts are very low, then patients present with more severe disease and more disseminated infections with fever, weight loss, positive blood cultures. Those that present with an NTM or MAC iris with high CD4 counts generally have fewer systemic symptoms, and their disease is more localized and more suppurative, like cervical adenitis or axillary adenitis or something like that. The treatment is to continue antiretroviral therapy, to continue MAC therapy, an approach of anti-inflammatories with NSAIDs first, and then if they have incomplete control, then steroids. Although remember, in my patient, he had cutaneous KS. So if his MAC iris required steroids, then he should also have chemotherapy to treat his KS concurrently, because steroid therapy alone has the great risk of worsening his Kaposi sarcoma. Continue ART. So MAC treatment overall, continue ART except in life-threatening situations, continue treatment of the OI. I just talked about this already. But in moderate to severe disease, steroids, but not in cryptococcal meningitis, although the latest DHHS guidelines suggest that some experts would consider it. Use steroids very carefully if KS is present, and consider concurrent KS therapy. Do not use steroids to treat KS iris. And remember to check for strongy if you're giving anybody steroids, or just treat them empirically with ivermectin. The other things here are listed as alternative to steroids, but they've only been published in case reports or small series. And this is from the DHHS guidelines. People with HIV on ART who develop moderate to severe symptoms typical of iris should receive initial treatment with NSAIDs. If symptoms do not improve, short-term, 4 to 8 weeks, systemic steroids at doses of 20 to 40 milligrams may be helpful. So I think I'll stop there.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.